This lecture is an overview of the chapter on neurologic manifestations of HIV and AIDS. I am Elena Grivensukova, and this presentation is also on behalf of my co-authors John Collins and Remus Lucas. Our objectives are to develop an appreciation of the many ways in which HIV can affect the nervous system directly, as well as indirectly via increased risk of nervous system infections, malignancies, and immune-mediated syndromes. We'll appreciate immune-mediated HIV complications that may mimic tumors and understand HIV-related opportunistic infections and malignancies associated with HIV. So we'll start with acute retroviral syndrome. This is an entity that typically occurs within about 2 to 6 weeks of the primary HIV infection and actually happens in nearly 25% of patients newly infected with HIV. These patients develop various neurological symptoms that may be vague, such as malaise and headaches, but may also present in a more specific way, such as aseptic meningitis. So patients complain of photosensitivity, headache, knuckle rigidity. They may have cranial neuropathy, such as facial nerve palsy, or radiculopathy, or even acute demyelinating polyneuropathy, such as Guillain-Barré syndrome. Next, we'll move into HIV-associated neurocognitive disorders. Approximately half of HIV seropositive patients are thought to have cognitive impairment. There are 3 large subsets of HIV-associated neurocognitive involvement. These are HIV-associated dementia, abbreviated as HAD or HAD, asymptomatic neurocognitive involvement, and mild neurocognitive disorder. In the era of antiretroviral therapy, HIV-associated dementia is rarely seen, but prior to antiretroviral therapy, it was very common among patients with HIV graduating to AIDS. Milder forms of cognitive involvement, such as asymptomatic neurocognitive involvement, which we see on neuropsychological testing, and mild neurocognitive disorder are more common today. HIV-associated neurocognitive disorder is characterized by a gradual decline in the cognitive functioning, often occurring long after the initial infection. So the perfect example would be a 20-year-old man who becomes infected with HIV, and 25 years later, even despite antiretroviral therapy, he is now complaining of attention issues, memory issues. Motor slowing is usually evident, sometimes coincident with, but often after the onset of cognitive decline. Neuroimaging typically reveals diffuse atrophy, and non-enhancing periventricular white matter changes may also be present. EEG usually shows diffuse slowing. CSF evaluation often reveals mild lymphocytic pleocytosis and elevation in protein levels, but it, of course, all depends on how immunocompromised this patient is and how chronic this illness is. So this is an MRI image that shows a typical example of HIV-associated neurocognitive involvement with sort of global impact that we would put under the term of encephalopathy, HAE. So the image A is a coronal T2 in a 24-year-old HIV-positive woman, and you can see that the ventricles and sulci are markedly prominent, indicating significant volume loss for a patient of this age. On image B, which is a FLAIR image of a 20-year-old HIV-positive woman, you can see also advanced volume loss, but in addition, you certainly can see severe diffuse white matter signal abnormality surrounding the ventricles. Next, we'll move to immune-mediated syndromes in association with HIV. These are rare, but they are nevertheless important because some of them can mimic tumors. So HIV-associated CD8 positive encephalitis, it was described only a few years ago. It is a rare entity. The syndrome occurs in virologically controlled individuals on antiretroviral therapy who nevertheless have evidence of HIV viral escape into the CNS. Some cases may be precipitated by a recent viral infection, such as an upper respiratory infection, but differ from the acute disseminated encephalomyelitis. It presents with features of acute encephalitis and responds to corticosteroid therapy. Magnetic resonance imaging shows diffuse white matter abnormalities affecting both white and gray matter with subtle punctate or linear areas of enhancement. This is an image that shows CD8 positive encephalitis in a 46-year-old HIV positive female that presented with subacute cognitive problems. So XLT2 flare on A shows patchy hyperintensity throughout the cerebral hemisphere affecting white matter and gray matter structures. XLT1 post-contrast on B shows diffuse streaky vascular perivascular enhancement. 3 weeks later, the abnormality had progressed to confluent parenchymal signal abnormality on T2. You can see that in the image C with new patchy diffusion restriction on DWI on image D. The patient was sent for stereotactic biopsy, which revealed a periventricular and parenchymal inflammatory infiltrate composed mainly of T lymphocytes and macrophages. Nearly all T lymphocytes were CD8 positive with almost no CD4 reactivity. Assays for an underlying infectious etiology were negative. Another syndrome associated with HIV that can be seen rarely is tumefactive demyelination. It presents with acute focal neurological findings and can mimic MS. MRI reveals tumor-like single or multiple lesions. Some of these lesions have an open ring configuration, C-shaped enhancement of post-contrast imaging, which is frequently seen in tumefactive demyelinating lesions. Tumefactive demyelination responds well to corticosteroid therapy. Antiretroviral therapy would need to be initiated at the same time if the diagnosis of HIV is concurrently discovered. Tumefactive demyelination should be strongly considered in the differential diagnosis of infections, gliomas, lymphomas, and other tumors of the central nervous system in a patient with HIV. This is an example of tumefactive demyelination MRI in a 35-year-old HIV-positive female that presented with left-sided weakness. So XLT2 on image A and T1 post-contrast on image B show two large T2 hyperintense and partially rim-enhancing lesions in the right cerebral hemisphere. Diffusion-weighted imaging on C demonstrates partial rim diffusion restriction confirmed on the ADC map that is not shown here. These findings, in particular the pattern of incomplete ring enhancement with the open end oriented toward the cortex, are characteristics of demyelination, specifically tumefactive demyelination. However, given the patient's lymphadenopathy, there was concern for lymphoma. A subsequent FDG PET study on D did indeed show some increased FDG uptake along the lesion rims, raising additional concern for tumor. The patient underwent stereotactic biopsy, which revealed a macrophage-rich lesion compatible with demyelination. Next, we'll move and discuss infections in association with HIV, and more specifically, typical of AIDS or AIDS-defining illnesses. Toxoplasmosis. Toxoplasmosis is called by Toxoplasma gondii, a ubiquitous parasite. Human contact occurs by exposure to oocytes and cat feces, but can also occur by exposure or ingesting meat that is undercooked, such as pork. CT and MRI reveal varying numbers of nodular or ring-enhancing lesions with surrounding edema. Typical locations are gray-white matter interface and in the basal ganglia and thalamus. The degree of enhancement varies depending on the severity of immunodeficiency, so more immunocompromised means less enhancement. Although signal characteristics vary, the lesions are often hyperintense on T2 weighted sequences. The center of the lesion may be hypointense on diffusion weighted imaging, with the surrounding edema being hyperintense. This is an example of an MRI of a 40-year-old HIV-positive male who presented with seizures, and the CSF was positive for toxoplasma by PCR. Here in T2 weighted imaging and T1 post-contrast on A and B, and the cerebellum C and D show numerous edematous enhancing lesions. Toxoplasma lesions can be found truthfully in any location, and they may be single or multiple, and they may exhibit any imaging structure from solid enhancing to ring enhancing or a combination of both. The classic appearance for toxo is a ring-enhancing lesion with an eccentric enhancing nodule, which you can see on image B, pointing an arrow. Next is one of the most probably famous infections that are AIDS-defining infections is cryptococcal meningitis, cryptococcosis. Cryptococcus neoformis is found in bird excrement and infects humans via inhalation. It then lays dormant in the lungs and reactivates in the setting of immune compromise and travels to the brain where it can set off an infection. Cryptococcal infection of the brain takes numerous forms. You can have basilar meningitis, which can result in hydrocephalus. You can have miliary parenchymal nodules, single or multiple parenchymal nodules, because of its tendency to infiltrate the brain via the perivascular spaces. Cryptococcal infection may also cause dilation of the perivascular spaces with or without enhancement, the so-called gelatinous pseudocyst presentation. And this is an example of an MRI imaging of a male patient, 55 years of age, with HIV, who had biopsy-proven active cryptococcal infection of the skin and then presented to us with headaches. So axial T2 on A and T1 on B show a single small enhancing lesion in the left corona radiata with moderate associated edema. The lesion resolved with targeted antifungal therapy, which is usually amphotericin followed by fluconazole. Next, we'll talk about progressive multifocal leukoencephalopathy, another AIDS-defining illness that can also be seen in people with any other causes of being immunocompromised, from chemotherapies to transplants to primary immunodeficiencies. So PML is caused by John Cunningham virus. John Cunningham virus occurs in up to 60 to 75% of normal healthy adults and is usually latent. It stays in the kidneys, in the salivary glands, and is asymptomatic, but adults can shed it. In the setting of immune compromise, it mutates into a neurotropic strain and migrates to the CNS, where it establishes a lytic infection. Symptoms are gradual and progressive, typically multifocal, and because of the blunted immune response, enhancement, edema, and mass effect are frequently absent. This is MRI example of PML in a patient who's 42 years of age, is HIV positive, who was diagnosed 8 years prior but never received any antiretroviral therapy. CSF showed high titer of JC virus. So you can look at the axial T2 on image A that shows white matter signal abnormality involving the right frontal lobe and insula, with spread across the corpus callosum to involve the left frontal lobe. Note involvement of the subcortical U fibers. Look at the arrows, and the nearly complete lack of mass effect. On T1 weighted post-contrast image on image B, note the complete lack of enhancement. This constellation of findings is classic for PML. Next, we'll talk about one of the frequent tumors that we see in association with HIV, and that's primary CNS lymphoma, PCNSL. It is a rare non-Hodgkin's lymphoma that accounts for fewer than 5% of primary CNS tumors. In the developed world, PCNSL occurs in about only 2% of patients with HIV. The tumor is frequently multifocal. Symptoms range from nonspecific, non-localizing headache, mild encephalopathy, delirium, to those associated with discrete lesions in so-called eloquent areas of the brain. Primary CNS lymphoma in immunocompetent patients almost always manifests as non-hemorrhagic, solidly enhancing lesion. In immunosuppressed patients, lymphoma can manifest as a ring-enhancing lesion with cystic or hemorrhagic components, but a solidly enhancing lesion is still the more common appearance. On MRI, these are contrast-enhancing lesions with either hypodense appearance on computed tomography or low signal intensity on T1 or high signal intensity on T2 flare sequence, typically homogeneously enhancing. However, in the setting of HIV infection, the degree of enhancement certainly varies, just like with any other entity such as infection. And this is an example of two females, aged 29 on image A and 43 on image B, both with HIV and both with a diagnosis of primary CNS lymphoma by biopsy. The coronal T1 weighted post-contrast image on A shows a solidly enhancing lesion infiltrating the corpus callosum. Now another entity can do that, and that's PML, but PML generally does not cause mass effect. And the axial T1 weighted post-contrast image B shows a faintly rim-enhancing lesion in the right frontal lobe. We'll move on to the complications of treating HIV, and that's immune reconstitution inflammatory syndrome, known as IRIS. It basically represents worsening of opportunistic infection in a patient with HIV, AIDS, who has recently begun antiretroviral therapy. This is a result of an exceptionally vigorous response of the newly reconstituting immune system to a pre-existing infectious agent. Iris has been associated with PML, tuberculosis, and cryptococcus infection, and the imaging features tend to resemble those of the original infection but with more severe or exaggerated findings. So this is MRI imaging that shows a case of Iris in a 55-year-old man with HIV with history of PML who presented with fevers and a headache 3 months after initiating antiretroviral therapy. And on T2 image on A, you can see very extensive confluent signal abnormality in the white matter of the left cerebral hemisphere and to a lesser degree of the right hemisphere. At first glance, the appearance is similar to that of progressive multifocal leukoencephalopathy. In this patient, however, there is far more mass effect than what is typical with PML. The T1 weighted post-contrast image on B, however, reveals the presence of ill-defined but unmistakable enhancement, a finding that is atypical of PML as well. So this concludes our review of the chapter on neurologic manifestations of HIV and AIDS. Thank you.